Welcome to Block Simulation 1. 20 questions, 30 minutes, 90 seconds each. The rules: read the command first, scan for key clues, build your differential fast, lock the answer and move. No second guessing. Every question gets the full screen. Read it like the real exam. Let's go. Read the command, most likely diagnosis. Now scan the stem. 4-year-old nephrotic syndrome, massive proteinuria, low albumin, edema, no hematuria, normal complement, post-URI, but no hematuria means this is not post-strep GN. Build your differential. FSGS, nephrotic, but rare in this age without risk factors. Membranous, older adults, secondary causes. MPGN, low complement, hematuria. IgA, hematuria during URI. Minimal change disease. Child, nephrotic syndrome, normal complement. No hematuria. That is the pattern. Minimal change disease. Most common nephrotic syndrome in children under 8. Electron microscopy shows effacement of podocyte foot processes. Invisible on light microscopy. Normal on immunofluorescence. Excellent response to corticosteroids. If the question shows a biopsy finding, the EM effacement is pathognomonic. FSGS will show segmental sclerosis on light microscopy. Different distribution, worse prognosis. Read the command, which hemodynamic profile. Dilated cardiomyopathy, EF 22%, that is severely reduced systolic function. S3, JVD, crackles. The heart cannot pump forward and blood backs up. The ventricle cannot squeeze, cardiac output drops, blood backs up into the pulmonary circuit, PCWP rises, the body compensates by vasoconstricting as VR rises to maintain perfusion pressure. That is the cardiogenic profile, low output, high filling pressure, high resistance. Contrast the other profiles. Choice A is septic shock, high output, vasodilated. Choice C is hypovolemic shock, low output, low filling pressure, vasoconstricted. Choice D is septic or neurogenic. The S3 gallop clinches cardiogenic. It is the sound of blood hitting a dilated, non-compliant ventricle in early diastole. Read the command. What distinguishes this from the other major? IBD. So they have already told us this is Crohn's. Skip lesions, transmural, non-caseating granulomas, fistula. The question asks for the distinguishing feature versus ulcerative colitis. Crohn's versus UC. Crohn's is transmural, can affect any GI segment, mouth to anus, has skip lesions, forms granulomas, causes fistulas and strictures. UC is continuous from rectum proximally, mucosal only, no granulomas, no fistulas. PSC, choice B, is actually more strongly associated with UC, not Crohn's. Colorectal cancer, choice E, HE, higher in UC. Toxic megacolon, choice D, higher in UC. The trap here is PSC, many students associate it with Crohn's. It is predominantly associated with UC. About 70% of PSC patients have UC. Crohn's is associated with gallstones due to terminal ileum involvement impairing bile acid reabsorption, a different biliary complication. Read the command, what explains the anemia. Drug exposure, primaquine, an oxidant drug, African American male, Heinz bodies, bite cells, Coombs negative, not autoimmune. G6PD deficiency. G6PD generates NADPH via the hexose monophosphate shunt. NADPH keeps glutathione reduced. Glutathione neutralizes oxidant stress, Without G6PD, oxidant drugs like primaquine, dapsone, and sulfonamides denature hemoglobin. Heinz bodies form. Macrophages bite out the Heinz bodies. Bite cells result. Intravascular hemolysis follows. Intravascular hemolysis. Bite cells result. Intravascular hemolysis follows. Coombs is negative because there are no antibodies. It is a direct oxidant injury. Spherocytosis, choice B, produces spherocytes, not bite cells, and Coombs can be positive if immune-mediated. Hereditary spherocytosis is Coombs negative, but shows spherocytes and responds to osmotic fragility testing. Pyruvate kinase deficiency, choice E, also causes hemolysis, but no Heinz bodies and is not precipitated by oxidant drugs. Read the command. Pathophysiology. High TSH, low T4, primary hypothyroidism, positive anti-TPO antibodies, classic autoimmune hypothyroidism, Hashimoto's thyroiditis. Hashimoto's is the most common cause of hypothyroidism in iodine-sufficient countries. The mechanism is autoimmune. Cytotoxic T lymphocytes and autoantibodies against thyroid peroxidase and thyroglobulin destroy follicular cells. The thyroid is infiltrated with lymphocytes and germinal centers. Form. The classic lymphocytic thyroiditis on histology. High TSH is the compensatory response to low T4 production. Choice A. TSH, secreting pituitary adenoma, would cause high TSH, and high T4, not low T4. Choice C. Autonomous nodule causes hyperthyroidism with suppressed TSH. The pattern high TSH, low T4 always means the problem is in the thyroid itself, primary. Low TSH, low T4 means the problem is pituitary or hypothalamic. Secondary. Read the command. Which medication reduces mortality by preventing remodeling? Stable HFrEF. Already on ACE inhibitor and diuretic. The question is, asking for the next mortality, reducing drug. Carvedilol is a non-selective beta blocker with alpha-1 blocking activity. 3 beta blockers have proven mortality benefit in HFrEF: carvedilol, metoprolol succinate, and bisoprolol. They block the chronic catecholamine-driven remodeling that enlarges and weakens the ventricle over time. The critical rule: start only when the patient is euvolemic and stable, not during acute decompensation, where negative inotropy would worsen the acute episode. Digoxin, choice A, improves symptoms and reduces hospitalizations but has no mortality benefit in a narrow therapeutic index. Nifedipine and amlodipine, negative inotropes, generally avoided in HFrEF. Hydrolazine plus nitrate is used as an alternative to Akia-ARB, particularly in Black patients, but is not the next step here. Read the command. What explains the metabolic abnormalities? High sodium, low potassium, high bicarb, suppressed renin, elevated aldosterone to renin ratio, adrenal adenoma on CT. Primary hyperaldosteronism, Conn syndrome. An adrenal adenoma secretes aldosterone autonomously without angiotensin II stimulation. Aldosterone binds mineralocorticoid receptors in the collecting duct. Sodium and water are retained. Potassium and hydrogen ions are secreted. Result: hypertension, hypokalemia, metabolic alkalosis. Renin is suppressed because the body senses high aldosterone and shuts off the ReLES upstream. Key discriminator: renin. In secondary hyperaldosteronism, renal artery stenosis, heart failure, cirrhosis, both renin and aldosterone are elevated. In primary, renin is suppressed because the signal is coming from the adrenal itself, not from the RAAS. Licorice, choice. D. Inhibits 11-beta HSD2, allowing cortisol to activate mineralocorticoid receptors, but renin would also be suppressed and there is no adrenal adenoma. Read the command. What explains the ocular findings? Ptosis and meiosis. Apical lung mass, arm pain in C8, T1 distribution. Ptosis plus meiosis. That is Horner syndrome. Ptosis, meiosis, and hydrosis. Pancoast tumor. Superior sulcus tumor at the lung apex. It invades the sympathetic chain as it exits at T1, causing Horner syndrome. The sympathetic innervation of the eye controls the superior tarsal muscle, minor levator, ptosis, the dilator pupillae, meiosis when lost, and sweat glands anhidrosis. Simultaneously, C8 T1 nerve roots are compressed. Medial forearm pain, fourth and fifth finger numbness, intrinsic hand weakness. Choice A. CN3 compression causes a blurring, dilated pupil, not meiosis, and down and out gaze. Horner is specifically ptosis plus meiosis. The pupil is small, not large. The distinction is critical. Dilated pupil means CN3 or sympathetic overactivation. Constricted pupil means sympathetic disruption. Horner. Read the command. Which structure is injured? Midshaft humerus fracture. Cannot extend wrist or fingers. Wrist drop. Decreased sensation. Dorsal first web space. Radial nerve runs in the spiral groove of the humerus and is the classic injury with midshaft fractures. It supplies all wrist and finger extensors. Wrist drop results. Sensory territory, dorsal forearm and hand, particularly the first web space. Thumb opposition. Choice. A territory, median nerve, is intact, ruling out median nerve injury. Grip strength is preserved because finger flexors are median and ulnar. Anatomy landmarks, surgical neck of humerus, pot axillary nerve, deltoid weakness, midshaft, pot radial nerve, wrist drop, medial epicondyle, pot ulnar nerve, claw hand, fourth and fifth fingers, supracondylar, anterior interosseous nerve, cannot make OK sign. Axillary fracture, musculocutaneous nerve, weak elbow flexion, decreased lateral forearm sensation. Read the command. Mechanism. Tampon use, high fever, diffuse erythroderma, hypotension, negative blood cultures. Shock without bacteremia. The rash involves palms and soles. Important detail. Toxic shock syndrome, Staphylococcus aureus, producing TSST1, a superantigen. Superantigen bypass normal antigen presentation. Normally, a peptide antigen is processed and presented in the groove of MHC2 to a specific T cell. A superantigen instead cross-links MHC2 directly to the vitae region of the T cell receptor outside the antigen binding groove. This activates up to 20% of all T cells simultaneously, compared to 0.01% in a normal immune response. The cytokine storm produces fever, vasodilation, hypotension, and rash. Blood cultures are negative because bacteria are not in the blood, the toxin is. Choice E. Direct bacterial invasion would give positive blood cultures. Choice A. IgE in mast cells is anaphylaxis, requires prior sensitization, and causes urticaria, not diffuse erythroderma. The palms and soles involvement is classic for TSS and also for secondary syphilis. Read the command. What explains refractory hypoxemia on 100% oxygen? PO2 of 52 on 100% VO2. Elevated AA gradient does not improve with more oxygen. The hallmark of shunt hypoxemia that does not correct with supplemental oxygen. In a shunt, blood completely bypasses ventilated alveoli. It flows through collapsed, flooded, or non-ventilated lung units and emerges fully deoxygenated into the pulmonary veins. Adding oxygen to working alveoli cannot help blood that never contacts them. Increasing phi-O2 increases PaO2 in ventilated units, but the shunted blood mixes back and pulls the overall PaO2 down. Dead space. Choice D is the opposite problem, ventilated alveoli with no perfusion. Dead space causes hypercapnia and a normal or low AA gradient. It responds to oxygen. Hypoventilation, choice A, causes elevated PaCO2 and responds to oxygen. Diffusion impairment. Choice B, improves with supplemental oxygen because more oxygen diffuses even through a thickened membrane. Read the command, molecular consequence of T922, Philadelphia chromosome, CML, full myeloid spectrum, massive splenomegaly, low LAP. The Philadelphia chromosome T92922 fuses the ABL tyrosine kinase gene on chromosome 9 to the BCR gene on chromosome 22. The resulting BCR, ABL fusion protein, is a constitutively active tyrosine kinase. It continuously phosphorylates downstream signaling molecules, driving uncontrolled myeloid proliferation. Low LAP distinguishes CML from leukemoid reaction, and extreme neutrophilia from infection or stress, where LAP is high because the cells are reactive and metabolically active. The other answer choices, context for rapid elimination, PML, RARA, RA, choice C is APL to 15, 17, BCL2 overexpression, choice E is follicular lymphoma to 14, 14, 14, 18, inversion 16, choice D is AML M4EO, RB1 deletion, choice A is retinoblastoma. Each translocation maps to one disease. Memorize the pairs. Read the command. How does test performance change with lower prevalence? Same test, different population. The sensitivity and specificity are fixed. They are properties of the test. What changes with prevalence is predictive values. In the rural ED with lower prevalence, most women with dysuria do not have a UTI. When you run a positive test in a low prevalence population, the proportion of true positives relative to false positives drops. PPV decreases. Conversely, most negative tests are truly negative. NPV increases. Sensitivity and specificity are intrinsic to the test. They do not change based on who you test. Intuition. In a room where 1 in 100 has a disease, a positive test is probably wrong. In a room where 99 in 100 have it, a positive test is almost certainly right. Same test, same sensitivity, same specificity, completely different PPV. This is Bayes' theorem in clinical practice, and it is tested constantly. Read the command, which enzyme deficiency, Ashkenazi Jewish child, hepatosplenomegaly, bone pain, anemia, thrombocytopenia, no neurologic findings, large macrophages with wrinkled cytoplasm, that is the diagnostic description. Gaucher disease, glucocerebrosidase deficiency. Glucocerebroside accumulates in macrophages of the liver, spleen, and bone marrow. The Gaucher cell is pathognomonic, a large macrophage with wrinkled, crumpled silk or tissue paper cytoplasm. Type 1. Gaucher, no neurologic involvement, is the most common lysosomal storage disease and the most common in Ashkenazi Jewish patients. Bone pain results from marrow infiltration and avascular necrosis. Treatment: enzyme replacement with imiglucerase. Quick elimination, sphingomyelinase, choice A, is Niemann-Pick, also Ashkenazi, but has neurologic decline and a cherry red spot in Gaucher. Ixosaminidase A, choice B, is Tay-Sachs, cherry red spot, no hepatosplenomegaly, fatal in infancy. Alpha-galactosidase, choice C, is Fabry disease, painful neuropathy, angiokeratomas, X-linked. No cherry red spot in Gaucheratomas, X-linked. No cherry red spot in Gaucher. Read the command, which neurotransmitter changes, explain the involuntary movements. CAG, repeat on chromosome 4, caudate atrophy. Father died at 49. Autosomal dominant with anticipation, Huntington's disease. Huntington's causes selective degeneration of GABAergic and cholinergic interneurons in the striatum, particularly the caudate nucleus. GABA normally inhibits the indirect pathway of the basal ganglia, which suppresses unwanted movement. When striatal GABA is lost, that inhibition is released. The motor system becomes disinhibited, producing chorea, involuntary, flowing, dance-like movements. Acetylcholine is co-depleted, worsening the imbalance. Critical contrast, Parkinson's, choice A, is decreased dopamine in substantia nigra, pars compacta, causing bradykinesia and rigidity. Huntington has relatively preserved dopamine. That is why dopamine antagonists like haloperidol can dampen the chorea symptomatically. Two movement disorders, opposite dopamine relationship, opposite movement phenotype. Read the command, which describes this condition. Rapidly rising creatinine from 1.1 to 4.6 in 3 weeks. RBC CAS, NPO, ANSI positive. No immune deposits on immunofluorescence. Crescents on biopsy. Rapidly progressive glomerulonephritis, type 3 posse-immune, ANSI-associated. The posse-immune descriptor means few or no immune deposits on immunofluorescence. ANSI-A anti-neutrophil cytoplasmic antibodies drive neutrophil activation and direct vascular injury without depositing immune complexes. Crescents in Bowman space form from proliferating parietal epithelial cells, a sign of severe aggressive glomerular injury. This is the fastest progressing gene and requires urgent treatment, high-dose steroids, plus cyclophosphamide or rituximab. The 3 crescentic GN patterns, type I, anti-GBM antibodies, linear IgG on IF, Goodpasture syndrome, often lung hemorrhage and nephritis. Type 2, granular immune complex deposits on IF, lupus nephritis, post-strep GN, EGA, nephropathy. Type 3, posse-immune, no deposits, INCA positive, posse-immune, no deposits, NCA positive, microscopic polyangiitis, GPA, eosinophilic GPA. Read the command. Mechanism of this side effect. ACE inhibitor, dry non-productive cough, no infection, clear chest. X-ray. Classic drug side effect question. ACE. Angiotensin converting enzyme. Has 2 substrates, angiotensin Y, which it converts to angiotensin II, and bradykinin, which it degrades. When ACE is blocked with lisinopril, bradykinin is not degraded and accumulates. Bradykinin is a vasodilator peptide that also stimulates sensory nerves and cough receptors in the respiratory tract, producing a dry, persistent cough. This is a class effect of all ACE inhibitors and occurs in up to 20% of patients. The solution: switch to an ARB, angiotensin receptor blocker. ARBs block the 18-1 receptor downstream of angiotensin II production and do not affect bradykinin metabolism. No bradykinin accumulation, no cough. This patient has CKD with proteinuria. An ARB like losartan is equally effective for renal protection and blood pressure control. Read the command. Which structure explains the blown right pupil? Thunderclap, headache, worst of life. Right pupil 7 mm, non-reactive, right eye down and out, subarachnoid blood on CT. A fixed, dilated, non-reactive pupil with ipsilateral down and out gaze is CN3 palsy. The oculomotor nerve supplies 4 of 6 extraocular muscles and carries parasympathetic pupillary constriction fibers, which run on the outside of the nerve. An expanding posterior communicating artery aneurysm compresses CN3 from outside. The outer parasympathetic fibers are compressed first, causing pupil dilation. The motor fibers inside the nerve are affected next. Ptosis and down and out deviation follow as superior tarsal and extraocular muscles lose innervation. Critical discriminator, diabetic CN3 palsy spares the pupil. In diabetic mononeuropathy, small vessel ischemia injures the core motor fibers but spares the outer parasympathetic fibers. Rule: blown pupil equals external compression, surgical emergency. Pupil, sparing CN3 palsy in a diabetic equals ischemic mononeuropathy. Treat with glucose control. Read the command. What explains virologic failure? Maravaroc, a CCR5 antagonist. No resistance mutations. Now X4 tropic virus. Viral load rising. Maravaroc blocks CCR5, the co-receptor used by R5 tropic HIV strains to enter CD4 T cells. It is highly effective against R5 tropic virus. However, HIV also exists as X4 tropic strains that use CXCR4 instead of CCR5. In some patients, a minor X4 tropic population exists at baseline but is below the detection threshold of standard tropism testing. When CCR5 is blocked, R5 virus is suppressed, but the X4 tropic minority is completely unaffected and expands. It is using a different receptor that Maravaroc does not touch. This is null classic resistance. No Maravaroc binding mutations are present. It is outgrowth of a pre-existing minority variant. The clinical implication: tropism testing must be performed before starting Maravaroc. If X4 virus is detected at baseline, Maravaroc should not be used. Enhanced sensitivity tropism assays can detect minority variants down to 2% frequency. Failure here means switching away from CCR5 antagonists and optimizing the backbone. Read the command. Which hypersensitivity type? ABO incompatibility, acute hemolysis, hemoglobinuria, shock developing within 30 minutes, acute hemolytic transfusion reaction, type 2 hypersensitivity. The patient has preformed IgM antibodies against the transfused ABO antigens. IgM activates the classical complement pathway, forming the membrane attack complex on donor red blood cells. Intravascular hemolysis results. Hemoglobin spills into the urine, hemoglobinuria, and into the circulation. Hemoglobinuria and into the circulation. Hemoglobinemia. Complement byproducts cause fever, chills, and back pain. Cytokine release and DIC can cause hemodynamic collapse. Before hypersensitivity types for rapid recall. Type 1, HEE, mast cells, anaphylaxis, atopy, immediate, minutes. Type 2, IgG or IgM against cell surfaces. Hemolytic transfusion, good pasture, Graves, myasthenia gravis. Type 3, immune complex deposition, serum sickness, SLE, post-strep GN. Type IV, T-cell mediated, no antibody. Contact dermatitis, TB skin test, transplant rejection, delayed 48 to 72 hours. Block complete. 20 questions. Let's lock in the 5 biggest traps. 1. Shunt versus dead space. Shunt, hypoxemia that does not respond to 100% oxygen. Dead space, hypercapnia, responds to oxygen. The O2 response is the discriminating test. 2. Blown pupil. Fixed, dilated pupil with down and out gaze after thunderclap headache. Posterior communicating artery aneurysm compressing CN3. Pupil sparing CN3 in a diabetic ischemic mononeuropathy. These two must not be confused. 3. Predicted values change with prevalence. A test in a low prevalence population will have lower PPV even with identical sensitivity and specificity. Sensitivity and specificity are fixed. PPV and MPV move with the population. 4. In APL, standard 7+3 chemotherapy can be fatal by releasing procoagulants and worsening DIC. Always ATR first. It is the anti-leukemia vitamin. 5. Myriabuic failure without resistance. Mutations means X4 tropic minority virus outgrowth. The CCR5 receptor is blocked, but CXCR4 tropic virus expands unchecked. That is block simulation 1. Train the process. Read the command. Scan for clues. Commit. StepLogic. Learn how to think, not memorize. Subscribe for the daily question and block simulation 2 next week.